Hello and welcome to the EMSNation podcast. I'm your host, Faizan Arshad. We continue our live podcast series from New Orleans, Louisiana at the 2016 EMS World Expo Convention, the largest EMS convention in the United States. We are so excited today. We have the author team for the Advanced GEMS course, which just held its beta test yesterday. It was a sold-out crowd. The reviews were rave, and we would love the opportunity to tell you all about this brand new NAEMT course. So without further ado, I'd like to introduce the authors. First up, we have Dr. Lance Villers.
Howdy, Lance Villers from San Antonio.
Hello, Wayne Burdett from Atlanta, Georgia.
Hello, Keith Woodmeyer from Philadelphia, Pennsylvania.
Hello, Troy Reynolds from College Station, Texas.
So nice to have you guys here today to talk all about the Advanced GEMS course. And just to define GEMS, we're talking about GEMS, Advanced GEMS. Can you tell us a little bit about the difference between the traditional GEMS course as well as the goals of the Advanced GEMS course? And why is this course absolutely necessary for our pre-hospital care providers?
Absolutely. So when we're talking about GEMS, it's Geriatric Education for EMS. It's been around for a little while. It was a conjunction course with the American Geriatric Society, and the purpose was that as our aging population grows and our run volume in EMS increases, we needed to provide better education for our EMS providers to manage these patients because of the various comorbidities, the various communication issues, and there's a variety of things that are just unique to this population. A few years ago, we came out with the GEMS Core Course, and the Core Course is an excellent overview of the topics within the geriatric community that we needed to address. There's a big emphasis on death and dying. There's a big emphasis on polypharmacy, on communication. There's some excellent psychomotor activities that we do to simulate the various issues that go on with the geriatric population and increase provider empathy, such as having providers communicate with each other wearing earplugs and gloves and things like that to simulate the dexterity and the audio issues that they may encounter. After we created the core course, we ended up going through and identifying a need for additional information. As we were developing this, we tried to get as much as we can into the 8-hour core course, but there's just so much content in there. So after we identified the need for the Advanced GEMS course, we developed this course that is really like no other course that I'm aware of out there in a national front for this topic area in particular. There's a de-emphasis on PowerPoints and didactic activities with an emphasis on psychomotor activities. So the overarching theme of the course, you're responding to a evacuation of a nursing home. It's important to realize that the disaster component isn't necessarily because we're teaching disaster modalities. It's more so we can encounter a variety of patients within the time frame of the course.
Keith, thank you so much for that introduction. There's a lot that I want to dig into there. First of all, though, can we talk a little bit about the need for geriatric education? What data do we have, and what do our current GEMS instructors have to say about the need for additional content, information, and education?
In the summer of 2015, we sent out surveys to current GEMS instructors to determine if we felt that the GEMS community, the current community, needed additional geriatric education and really the training beyond the 8-hour core course. We submitted a survey, and what we found was interesting, and this is really the data that we use to put together the advanced course. Some of the topics that were most important were communication challenges, cardiovascular care, pharmacology and medication toxicity. And in terms of the skills, we recognize that this population, because they're living longer, there's more advanced medical care for this population and certainly more advanced care in the home setting where EMS personnel would be encountering these patients. So some of those skills included PICC lines, portacaths, wound care, home ventilators, feeding tube management. Interestingly, the controversial topic of spinal immobilization, we do address that somewhat, but more along the lines of it is a controversial topic. So we do have that discussion in the advanced course. But overall, what we found was that the majority of those who responded wanted an additional course. They wanted to be able to address a greater variety and complexity of scenarios, and of course to obtain more clinical knowledge.
Thanks so much, Lance. Wayne and Troy, as affiliate faculty for GEMS, what roles do you see the Advanced GEMS course providing for your students that have actually completed the core course?
We find that more knowledge is needed in dealing with PICC lines, PEG tubes, and implanted cardiac defibrillators. More and more patients are being sent home with these devices, and they need to know how to deal with them. And that is one of the things, is that when we get these patients at home, we need to realize that we need to truly assess the patient and not utilize that device. We need to treat those patients as exactly that, patients with those type of deals, and realize that we can access those devices if needed. And that truly is one of the big things. Treat them as patients, not treat those devices.
Fantastic. So what I'm hearing from you all is, one, we're expanding our medical knowledge and scope for the geriatric population. Two, we're focusing on the specific skills that are necessary to treat the aging population in America. And then three, also, we're focusing on a lot of the psychosocial challenges, communication challenges, and treating our patient as a whole.
I think you're right, and the advanced course takes you away from that PowerPoint and is great because it puts the students hands-on to those devices. It lets them see those devices. For instance, a student in one of the beta courses said she had no idea that an AICD was so heavy. And it lets them actually see that device where it's not just a picture underneath the skin, but they can put their hands on those different devices, see how they work and see how they operate, and like you said, treat the patient. Not just necessarily those devices, but treat the patient.
So we're expanding our knowledge of the anatomy and the physiology, as well as some of the implantable devices and exactly what their function is, and we're bringing that medical knowledge to life.
Right. For instance, showing where the PEG tube actually goes in, instead of just, okay, here's a PEG tube, it's inserted through the abdomen, showing how it's inserted into the abdomen and where the different spots and, the different devices, can be put into the abdomen and utilized.
And realize that once those are placed into the body, that we need to go back and assess them and treat them as a patient. One of the key things that we saw yesterday was that a lot of practitioners already deal with these, and that what we need to do is go back to looking at that patient and treating that patient as a whole.
Something else I think is important to highlight is some of this equipment within the industry, people automatically identify as, critical care level. For example, ventilators. These are patients that are getting sent home on home ventilators. They've been on ventilators for months, if not years. It's not concepts that we're trying to teach about how to change ventilator settings or things like that. We're trying to apply the airway and ventilation knowledge that we know as EMTs and paramedics to this closed circuit system that exists. And we're trying to take out some of that fear that people have, thinking, well, that's critical care, I can't touch this. Because in all reality, this patient can sit home by themselves and be okay. We're just trying to get some of that information out so people realize that, they think they don't know a lot about ventilators, but they know a lot more than they really think. It's just applying the knowledge of airway and ventilation to that device and that patient.
So breaking down fear in regards to expanding the core medical knowledge and describing some of the devices and how they interact with the human body.
And I think the fear, you could even go further with the PICC line. It's just out there that, we can't access a PICC line. We have to start peripheral access, and the population that have those PICC lines, their veins have already, suffered enough. And so, right, it takes that fear away from utilizing the PICC line and how we can utilize it, so that we can benefit our patient.
So this is a fascinating conversation already. What I'd like to do is take a step back and discuss the overarching goals of the course and describe the 8-hour day in general, and then really dig into some of the specifics. So when you all met as an author team, the global goal or need was to use a unique and evolving patient scenario. The student will be able to appropriately recognize, assess, treat, and transport the older patient using the most up-to-date, advanced level techniques in geriatric care. How did you all come up with that, and really what does that mean?
With the overall evolving scenario, that's where the disaster comes into play, because we wanted it to go where providers would see one patient, then the next, while it was staying reasonable within the time frame of the course. And we also wanted to be able to provide an introductory patient into that medical device or scenario. So, for example, I'll use vents. We had one patient who's rock solid stable, just going from point A to point B, just because of this evacuation. And it gives them an opportunity to become familiar with the device, for the transferring nurse or RT to go over the device with them and allow them to review the different parameters and know what they need to check before, during, and at destination. And then the following scenario immediately after has a lot less input from the transferring team, and it's more on the crew. So it allows us to go from patient to patient, but that scenario continues to evolve.
The GEMS committee recognized that we had this list of somewhat isolated skills to discuss, the LVAD and PICC lines and ventilators. And we felt like creating a disaster response scenario best enabled the course to present these kind of isolated skills in a more unified approach. And it's not a disaster response course, but we couch the course as a response to a disaster evacuation.
That sounds like a fascinating way to structure a course, and certainly an advanced educational style. I know there's a lot of fatigue out there in regards to death by PowerPoint lectures, and that was one of your goals, certainly. Can you describe the 8-hour day? How do you really develop that scenario and disaster, and how do you create the building blocks for practitioners to establish that skill set throughout the day? And I know there's a massive focus on activities, hands-on training, and the physical association with some of these devices to expand knowledge.
The class begins as if you're a responding crew to a disaster evacuation. So again, the committee felt very strong that we didn't want to have a class where the student had to sit in a chair for 8 hours. So again, we wanted to create an environment, a classroom environment where students were up and moving and encountering the education process rather than passively receiving it. So the day begins in the class as if you're a responding crew, and you enter into a situation where you have a triage officer has given you some orders for a patient to be transferred from one facility to another. And then in those individual cases, there's patient information, there's full patient charts, there's medical history, medications, past medical history, the information that a crew would have, a packet of information that a crew would have in real life if they were transporting a patient or evacuating a patient. So we discuss the patient, the history, the past medical concerns, medication concerns, and again, to interface with those advanced topics of when a patient has an implanted cardiac defibrillator or has a PICC line or has a ventilator.
I just wanted to expand on one of the things that Lance was saying. With the patient records, I think that was a really important aspect because it's not really taught in initial EMS education. And what a MAR is, going over the medication administration records, going over their history and physical, going over just the components of a face sheet, where you find that information, where you can find that history, where you can cross-check what you got on report versus what's in their record. And I think having the full record for each patient, on the vents, we've got the flow sheets. For the AICDs, we've got the information for where it was implanted, who the cardiology group that did it. And it's information that's not taught in initial education, but it's stuff that people are encountering either in private transport or in a facility or in 911. If they're transporting a patient, if they get called to a nursing home or something like that, they're going to get this information. And it's stuff that we traditionally have not taught.
I completely agree, Keith. As an emergency physician and an EMS physician, I think really expounding that patient handoff, how to do that proper assessment of your elderly patient that may have multiple comorbidities, that may be on several medications, on a complex regimen, and really focusing in on the acute presentation and being able to fill in that background. And when EMS practitioners are able to effectively do some of that homework and present that patient and hand off that patient to me in the emergency department, I know we really, really can optimize the care for that geriatric individual, because we're already on the ground running. We have a great idea, we have a great overarching view of this patient and the patient's needs and history, and then we can really focus in on the problem at hand. So I 100% agree. We need to do a better job on training providers to dissect those complex records.
And one of the things is that knowing where to find that information out in that patient paperwork. A lot of times practitioners don't realize that that information is there, and all they have to do is look back into that patient paperwork and find the information. And one of the key things, like with the implanted cardiac defibrillators, is that every one of those patients is given a patient card that they're supposed to carry in their wallet, and that information is there. All they have to do is look at it, and once they call the numbers, it activates the information. So where they're delivering that patient at, that information is already going to be there. And so that it makes it easier for them. But a lot of practitioners don't know that. They don't know that once they call the number, it automatically generates that information that they need. And that's one of the things.
I think another point with that is common practice within the hospital is identifying a patient with 2 patient identifiers. And before picking up our patients from a nursing home or something like that where there's multiple patients, it's not something that we commonly teach, is verifying your patient. But it's something that we should be doing. So going through, having your chart, talking to your patient, asking them their name, their date of birth, along with your assessment, evaluating your A&O times 4, you're also verifying that that is the patient you're supposed to be transporting.
Even more important in a disaster situation where we're transporting patients in a very hectic and confusing time.
Especially with dementia, I can imagine there's great opportunity to expand in a rolling disaster scenario that you have set up. Patient tracking is going to be a challenge. Communicating with your team as well as the patients at large, as well as the facilities that you're transferring them to, whether they be other long-term care facilities or the emergency department or other alternate destinations within your scenario, I would imagine is certainly a complex challenge.
One of the things about the Advanced GEM program is that getting to learn that you can access some of those devices, and the simple ways to simply check to make sure that they are flowing properly, and that things that as practitioners we can access them and make sure that they're flowing properly. And that a lot of times what we get are patients that aren't taken care of properly in some of these settings, and just by doing some simple things we can correct the issues that are at hand. PEG tubes, PICC lines, things like that. Just doing some simple taking care of the patient, we can make it easier on that patient and make it easier on getting those patients to the most appropriate facility.
Fantastic, guys. Well, you have certainly piqued our interest in not only taking the GEMS course, but now expanding the knowledge base, the core medical knowledge, skills related with complex devices, which are becoming increasingly common, and breaking down the fear component by expounding the anatomy, expounding the physiology, and really bringing that patient care in a global view to the forefront. So I'm sure that folks that are listening in are going to be excited to not only take the course, but potentially become instructors. Keith, I know that you are holding the third beta for this course in suburban Philadelphia on October 23rd. Can you talk to the third beta? How might folks enroll in that course? And then generally speaking, how would one take the Advanced GEMS course once it goes live? And then if you could briefly describe the process of becoming an instructor for the course.
The third course that's coming up, it's in suburban Philadelphia. You can reach out to me on my Twitter handle or by email. It's micuparamedic@gmail.com. Either to find out if there's any spots open. I think we might still have a few spots open. I'm not 100% positive, but I know it is limited seating. As far as becoming an instructor and how to offer the course at your location, there's a few different paths. One, if you are currently an AMLS instructor, then you can go ahead and take a core GEMS course, and then we are going to be offering an online transition for instructors to be able to offer the Advanced GEMS course. So those AMLS instructors will be able to offer both the core and the advanced. If you do not hold an AMLS instructor, then you can go ahead, take the core GEMS course, take the online NAEMT instructor course, and take the Advanced GEMS course. And then you would have to be monitored for the Advanced GEMS and would be able to teach that at your location.
Fantastic. And is there anything else that you guys would like to say to our audience about the Advanced GEMS course beta?
It was pretty awesome.
Fantastic.
It was a good time. I mean, it sounds silly, but it was just, we were up, we were going around, everybody was moving, and everybody was having fun. It was a really engaging experience, and I know as an instructor, I really enjoyed teaching it.
One of the unintended objectives we discovered was the reduction of fear for providers to be able to face these complicated pieces of equipment, to face the complicated anatomy and physiology of care for patients that have these pieces of equipment applied. So knowing that the students came out realizing that they have been empowered to take care of these patients, that was a powerful 8 hours yesterday.
And I think it was done, and what made it a great course too was that it took them out of the classroom and put their hands on the devices. So the writers did a great job with doing that. Instead of here's the device on a PowerPoint, you actually took it hands on, this is what it is, and you need to utilize the device and see it and use it.
And it was great knowing that the students are able to go ahead and relax, because a lot of times, death by PowerPoint, they get edgy at the end. But in this course, they're able to step in and, in a way, play with these devices and realize that we can access them, and realize that what we really need to do is treat the patient as just exactly that, a patient, and not be afraid to utilize these devices if we have them.
Fantastic. That sounds like a great place to leave off. We're going to link to each author's Twitter handle and email address in the show notes, so certainly look that information up if you have further questions or comments for our committee. This is Lance Villers, Wayne Burdett, Keith Widmeyer, Troy Reynolds, and Faizan Arshad wishing everyone a safe tour.